Hi everyone, my name is Pooja Verma, and I'm really excited to be joining you all virtually for this Kama Meet. A big thank you to Professor Lee for inviting me to be a part of this. And today I shall be talking about the role of vocal physiotherapy in muscle tension dysphonia. To give you a little bit of background, I'm a physiotherapist. I specialize in working with performing artists. I have a master's in performing arts medicine from UCL in London. I've done a lot of work both in London and Singapore with performing artists. So I treat actors, singers, dancers, circus artists, a wide variety of performing artists. And I also do a lot of work with shows such as Wicked, Phantom of the Opera, touring productions, and I've also done some work with the Royal Opera House in London. So for today's topic, we're just going to do a little bit of an introduction of what the voice is and what influences it before we deep dive into muscle tension dysphonia and its treatment. The voice. So we produce sound through the vocal folds. So the vocal folds or the vocal cords are located within the larynx, and these are essential for sound production. As the air passes through the larynx, the vocal folds vibrate, and this creates sound. We can change this pitch and tone by manipulating the tension and position of the vocal folds. The voice is influenced by many factors, the first one being physiological factors. For this, we're looking at the vocal cord health. So the health of the vocal cords plays a very important role in sound production. If there are any disorders or abnormalities such as nodules, polyps, any inflammation, that can affect the quality of the voice. The other thing that might affect it is your respiratory system, which is including the lung capacity and the control of airflow, which is important for sustaining and modulating the voice. The second big category is anatomical factors. So this would include the structure of your larynx, the size and the shape of the vocal cords, which can then influence the pitch and quality of your voice. And then we're also talking about the oral and nasal cavities. So the shape and size of the oral and nasal cavities can influence your resonance and the overall timbre of the voice. And then we have environmental factors. So if the temperature is hot and humid, the voice is generally more favorable in those conditions. But if it's dry and cold air, that can irritate the voice. Air quality is also an important factor. Any exposure to pollutants, smoke, or allergens can also affect your vocal cord functioning. Behavioral factors also play a role. So if you have a habit of speaking loudly, whether that's for work or just in general, yelling, or using improper vocal techniques, that can strain the vocal cords and contribute to voice problems. And hydration and diet play a big role. You need to have adequate hydration to maintain vocal cord lubrication. And certain food and drinks, such as caffeine and alcohol, can dehydrate both the body and the voice. Psychological factors such as your emotional state, so stress, anxiety, all influence the voice, and tension and nervousness may manifest as vocal tension, which can then affect your sound. And cultural and social influences such as language patterns and accents can also contribute to variations in vocal expression and subsequently in the amount of tension in the voice. And the last category being age and hormonal changes. So as individuals age, like every other part of the body, the vocal cords may also undergo changes, which can affect pitch and tone. And hormonal changes such as those during puberty can also affect the voice, such as the deepening of the voice in men and an increased pitch in females when it comes to menopause. Now, muscle tension dysphonia is the main topic of this presentation. So muscle tension dysphonia is one of the most common voice disorders. Muscle tension dysphonia is a clinical and diagnostic term used to describe a spectrum of disturbed vocal fold behavior, which is caused by an increase in tension of the paralaryngeal muscles. There are two main types of muscle tension dysphonia, the first one being primary muscle tension dysphonia, where the muscles in your neck are tense when you use your voice, but there is no actual structural abnormality in the larynx itself or in the vocal folds. Secondary muscle tension dysphonia is when there is an abnormality in the vocal fold or in the voice box that then causes you to overuse the other muscles to help produce sound. There can be many causes for muscle tension dysphonia. The most common ones include having to use your voice ineffectively for long periods of time, sudden changes in voice production because maybe you've had a period of overuse, or you've had an infection, or you've gone through an emotionally stressful period. It might be compensation for an underlying vocal fold problem, such as a cyst, or a nodule, or fatigue. It might also be a guarding response to acid reflux or some other irritant. Or it might be a combination of some or all of those factors. The symptoms of muscle tension dysphonia are typically vocal fatigue, which is the first thing that someone would experience, and then loss of resonance, breathy tone, constriction whilst voicing, loss of vocal range, whether that's in the upper register, middle register, or lower register, any neck or jaw tension, muscular pain in the extrinsic muscles, and effortfulness or difficulty with swallowing. So, what is laryngeal manual therapy? Laryngeal manual therapy is a non-invasive treatment that addresses the muscular tension in the perilaryngeal region that may affect one's ability to vocalize or phonate. This typically involves manipulating the larynx and the surrounding soft tissues that control the movement of the larynx. When artists, like any other athlete, develop a muscular imbalance due to repetitive use, then the ability to consistently perform that particular action or to seamlessly adopt a different muscular pattern may be compromised. This is where our role as manual therapists is highlighted in correcting this imbalance to either allow the artist to continue in their current capacity, where overuse and potentially technical deficiencies have resulted in these symptoms, or to restore the mobility to the restrictive areas, therefore improving the ability to change the vocal setups as needed. Laryngeal manual therapy is not speech therapy, and it is not vocal coaching. Instead, it does involve working with the ENTs, the speech and language therapists, and the vocal coaches and singing teachers to be able to address this. So it's a multidisciplinary approach, and we all work together to achieve that outcome of getting the singer or actor back to doing what they're doing. So what do we actually do? The larynx is suspended by muscles, which in turn are affected by your vocal workload and certain voice qualities, your abdominal muscle patterns, postural influences, reflux, illness, and injury. The aim of the laryngeal manual therapy treatment is to identify and treat any areas of restriction and address the reasons behind them. So not just addressing the symptom of tightness, but also addressing the cause for that tightness. So in this picture, you can see that there is the hyoid bone here. Your suprahyoid muscles attach to that hyoid bone, and the larynx is sitting below it, and your infrahyoid muscles attached to that as well. Tongue is above there. So we basically work within this area to try and achieve the outcomes that we need. If there's tension in the suprahyoid muscles, it will play an influence on the larynx because the whole structure gets pulled up. So the first thing we look at is your sternocleidomastoid muscles. These muscles can get tight, and tightness in them can result in recurrent headaches, jaw tension, and the classic text neck or forward neck posture. And that's the radiation pattern demonstrated there. The second thing that we look out for is asymmetry. So as you can see in the first picture, the tongue is lopsided. So it's curving down on one side and it's higher on the other side. And then we correlate that to what they're seeing in the stroboscopy, where you'll see that the arytenoid cartilage will be dropping down. So the side that's dropping down is the hypermobile side, and the side that's higher is the hypomobile side. So we're trying to create symmetry between the two sides. So we want the hypomobile side to be doing more work so that the hypermobile side can rest or doesn't have to constantly overwork. And just going back to that, we basically want to correlate what we're observing externally to what we're seeing on the imaging as well. The third thing we look at is the position of the larynx. So we're looking at the freedom of movement. Is it sitting higher? Is it sitting more posterior? Is it rotated? And we describe this based on anatomical planes as well. So we can talk about it in terms of like the sagittal plane, the coronal plane, just so there is congruency in how we're describing it. The laryngeal position is influenced by the pull of the surrounding muscles. And because the larynx is attached to the hyoid bone, as I explained earlier, these suprahyoid muscles that elevate the hyoid bone will also then elevate the larynx. Therefore, if the suprahyoid muscles that elevate, therefore, if the suprahyoid muscles are constantly tense, then the larynx will also be elevated at rest. And so this is what we usually observe in clients with dystonia, is that the larynx tends to be sitting a little bit higher than usual. This is just a quick diagram in case anyone hasn't seen the anatomy of the larynx. These are the structures that we're typically looking out for and working with. And now the other big component is looking at tongue tension. These muscles usually contribute to swallowing and mastication and to the floor of the mouth. They also elevate the larynx. There are usually three primary presentations in dysphonics. The first one is that the tongue is usually retracted back. The second is that there is an inability to move the larynx independently of the tongue. So every time they move their larynx, their tongue will pull back, or they're not able to differentiate the two. And the third is that the larynx tends to sit higher when you try to resist it with caudad movement, so downward movement. So we're looking at the hyoglossus there, and then we're also looking at the styloglossus. And usually when there is a restriction of the styloglossus, patients will report a loss of range in the M2 or the upper register, or they might experience difficulty negotiating the passaggio when they move to a higher register. And then we also look at the stylopharyngeus. A restriction here can result in the ability of the, because of its attachment, the stylopharyngeus muscle, if it gets restricted, it can reduce the ability of the cricothyroid muscle to rotate the cricothyroid joint to allow for vocal fold elongation, because it's a direct antagonist, which can then result in vocal issues, typically resulting in breathy phonation. These are the constrictor muscles. They can elevate the larynx, and they can also shorten the pharynx. They usually work during swallowing and speaking, and patients with a restriction in the middle pharyngeal constrictor muscles may report difficulty with swallowing as well. And tightness here can also result in the ability to control resonance. Now, what else affects the voice? So these were all of the muscular components, but there are also certain other things that we can look at and influence as physiotherapists. So the first one being posture. If your shoulder girdle is protracted, it does not allow, so if you're hunched over or rounded, it doesn't allow for efficient omohyoid activity, which then lowers the larynx, and that's a key component in reducing the influence of the overactive suprahyoid muscles. So a good posture is important. The other factor is if you're also rounded in, you're compressing the ability of the lungs to expand fully, so then you're influencing the lung capacity as well when it comes to singing. So we really need to be able to control those factors. The next thing is costumes. A lot of shows have interesting costumes. So, for example, the first image is of Lion King. In the Lion King, they have these big headpieces that tend to pull your neck and shoulder forward. So strengthening accordingly is important so you don't end up straining the wrong muscles. And in the second picture, that's kinky boots. So they're in heels for the most part. And again, that puts you in an anterior pelvic tilt, which can flare your ribs. So working on that posture and strengthening beforehand is also important. Just being mindful of the position and costumes that you're in, and how that can influence the voice as well. The next thing is choreography. In a creative industry, people keep trying to do new things, and we just have to find ways to be able to do them in a safe, healthy manner. So if your choreography involves being halfway through a back bend or with your neck all the way at the back and then trying to voice from that position, it's a lot harder. Dance background also plays a role. Dance and singing have two very opposing muscular demands. So usually people with a very strong dance background prior to starting singing might have some tension issues because of the change in the requirements of the muscle usage. And lastly, core. Core plays a huge role. I will demonstrate this with two videos of a patient that I took. So we'll listen to that again, but this was a patient that came to me. He basically reported feeling like he was restricted at the top of his range in the upper register and felt like he couldn't go any further, and his voice felt really weak at the top. There was nothing structurally wrong with him in the stroboscopy, but when we had an ultrasound scan of his core muscles, what we're looking at over here is that's the ultrasound probe. So you have your external obliques here, you have the internal obliques in the middle section, and you have your transverse abdominis in the lowest section. So what we're looking for is which area expands the most, and in his case you can see that the internal obliques are quite well developed. So we'll watch that again, and then we'll watch what happens after we gave some postural cueing tips to him. Let me play that again. So you can see that his transverse abdominis and his internal oblique both expand together. Ideally, what we want is for it not to co-contract, but for the transverse to expand independently of the internal oblique. Usually when the internal oblique comes in, that's a compensatory strategy, and that can typically result in that classic loss of the upper register or breathiness at the top. And this is after. And you can see that the transverse is more now, and so in this you can see that the transverse is holding its own, and the internal oblique is no longer taking over that movement, so it's not expanding more than the transverse is. And after this, so all we did was some pelvic tilt cues, some gentle transverse abdominis engagement cues, positioned him in different ways to try and get the correct activation, and he reported feeling more resonant. He reported no more restriction in his voice, and that his voice felt much smoother. So I'll play that again for you to see. So when should a vocal physio be consulted? If your patient is experiencing any of the symptoms mentioned before, so fatigue, which is the first thing that will creep up, hoarseness, breathiness, pain, difficulty swallowing, a feeling of a lump in the throat, loss of resonance, changes in their vocal range, whether it's the upper, middle, or lower register. Or sometimes people come in during maintenance during busy show periods or rehearsal periods because they know that the intensity is increasing, so it's just more preventative. So, in summary, vocal physiotherapy involves addressing the muscular tension surrounding the larynx and mobilization of the larynx and hyoid, to also including the addressing of posture and core to basically be able to address that tension. These are some resources if you're interested in the voice and in performing arts medicine. Thank you for your time today. I hope you enjoy the rest of the conference or meeting. These are my acknowledgements, these are my references, and this is my contact details. If you have any questions, feel free to drop me an email, and my socials are there as well. Thank you.